Deja vu all over again? The early experience with robot-assisted laparoscopic cholecystectomy in New York State. My disclosures. Introduced in the late 80s, lap chole replaced open chole in the 90s and became the standard of care. While this was a major advance for most patients with gallbladder disease, there was a significant learning curve. Most worrisome, there was an increased rate of bile duct injury in lap chole, and this can have catastrophic impact on both patient and the healthcare system. The benefits of lap chole versus open chole are well established and is currently the standard of care. However, the higher bile duct injury rate in the early lap chole experience compared to open chole was what one group described as the glaring blemish of the procedure. Early studies of lap chole BDI rate revealed up to 5 times higher injury rates lap compared to open. With time, surgeon training, and experience, that rate decreased to 0.2%. A more modern Sparks analysis revealed the contemporary lap chole BDI rate in New York State to be 0.08%. Although robotics was originally touted to aid in complex procedures, robot-assisted laparoscopic cholecystectomy has gained traction and is growing exponentially. Should we expect a seamless transition from lap to robot? Intuitively, the transition from lap to robot appears to be less significant than the rather painful transition from open to lap. Both RMIS techniques use laparoscopic visualization, and the robotic platform even has 3D optics. Most importantly, all surgeons attempting robot-assisted lap chole already perform and have mastered lap chole. What does the literature show? Well, the largest and most cited meta-analysis comparison studies of robotic versus laparoscopic cholecystectomy revealed a statistically significant increase in time and cost. However, BDI rate, conversion to open rate, and complications in most studies were similar and not statistically different. However, upon further analysis of these papers, expert robotic surgeons, in most cases, performing at single institutions, revealed their data. The largest series cited in these papers of 676 robotic lap choles performed at a single institution showed a statistically significant lower conversion rate. However, a major weakness was that they excluded surgeons who did less than 125 robotic cases in their experience. This is important because we know from the laparoscopic cholecystectomy experience that most BDI injuries happen in the first 30 cases of a surgeon's experience. Unlike industry-funded single institution comparison studies that dominate the literature with only 30-day follow-up, the question we sought to answer is, what happened in New York State when novice robotic surgeons first sat at the robotic console? Our analysis is a real-world, population-based, longitudinal study examining outcomes and resource utilization for a full year after the index robot-assisted laparoscopic cholecystectomy procedure. Sparks captures not only de-identified unique individual patients, but unique surgeon activity as well. As you can see, in New York State, there were 4 surgeons performing robot-assisted lap chole in 2009, and that has increased to 229 by 2015, the last date that we have available. In our analysis and methods, we examined all of the cholecystectomies performed in a minimally invasive fashion in New York State during the study period. The analytic sample after exclusions revealed 299,000 minimally invasive cholecystectomies performed in New York State, 0.4% of which were robot assisted. The preoperative Patient characteristics included age, gender, race, comorbidities, and what type of biliary pathology. The principal outcomes were minor and major interventions, where minor duct interventions included all repair procedures other than anastomosis to the intestine, and major interventions included all procedures with anastomosis of the biliary ducts to the intestine. The secondary outcomes included length of stay and 30-day outcomes. A SAS 9.4 statistical analysis was undertaken with both bivariate and multivariate analysis. The robotic patients were older. There were more African Americans represented in the robotic group, and the patients had more comorbidities. However, the laparoscopic group had worse biliary pathology. That is, the robotic patients tended to have more symptomatic gallstones, and the laparoscopic group tended to have more acute cholecystitis. Conversion to open was higher in the robotic group. Any bile duct complication was also statistically significantly higher. Minor and major interventions were nearly double in the robotic group. Intraoperative cholangiogram, however, was seen more frequently in laparoscopic cholecystectomy. This could have a protective effect. Overnight or longer hospital stays were more common in the robotic group. Readmissions, blood transfusions, parenteral antibiotics required after the preoperative dose, and incisional hernia were all higher in the robotic group. Complications over the time period actually increased in the laparoscopic group, but remained unchanged in the robotic group. Bile duct complications increased in the laparoscopic group over time, but they were unchanged in the robotic group. This is surprising, as surgeons gained experience with the robotic approach. One would have expected that these rates would decrease. Bile duct injury patterns mirror that seen in laparoscopic bile duct injury patterns. However, the 3D visualization afforded by the robot platform did not appear to mitigate or account for lack of surgical experience in the procedure. Also, tactile feedback of the laparoscopic cholecystectomy and the ability to feel and manipulate tissues also was taken away from the surgeons and may account for some of the increased rates of injury. Open conversion in robot-assisted lap chole versus lap chole was about double. Bleeding and unable to visualize the biliary tree were reasons for conversion in both the laparoscopic and robotic groups. But intraoperative cholangiogram, there appeared to be a disincentive, possibly due to OR ergonomics, for surgeons to undertake a cholangiogram. Robot-assisted lap chole was associated with longer OR times and increased hospitalization for robotic-assisted lap chole, though similar length of stays once admitted. The hospital charges reported by New York State for lap chole versus robotic chole was also statistically significant. Increased robot-assisted laparoscopic bile duct injury rate was eerily similar to the early experience of open chole to lap chole among novice surgeons. Our findings of a real-world BDI injury rate much higher than previously reported in the literature or expected, given surgeon familiarity with lap chole, was discovered. As robotic competencies become a standard in general surgery residencies, robot-assisted lap chole outcomes should be expected to improve. Robot-assisted lap chole should not be the first procedure of choice for robotic neophytes. Hernia may be a safer, early choice to gain competency on the robotic system, given the catastrophic effects of bile duct injuries. Thank you.